Myself, Dr. JIBRAN Ahmad presents to you Simply Pathology, and today we are back with a very important session. Today we are going to start with a very interesting topic, that is infertility. Okay, so we are going to discuss about both male as well as female infertility. Today we are going to see the part 1, that is the male infertility. Now very importantly, this is very commonly asked question in your exam, so please stay tuned till the end of this lecture. So what is infertility? Infertility refers to the failure of a couple to achieve conception after 1 year of unprotected regular sexual intercourse. Okay, so there are two kinds of infertility. Okay, so 40% of the cases they are primary variety of infertility and 60% of the cases are secondary variety. So what do you mean by primary infertility? When there is a failure of a couple to conceive from first, means they did not have any child before. So from first only they were not able to conceive. That is called as primary infertility. What is secondary infertility? Basically, secondary infertility is the condition when there is a failure to achieve conception after previous pregnancy. So previously there was pregnancy, the person had conceived before, but right now they are not able to conceive. So that is the secondary infertility. Okay. So if you look at the statistics, around 80% they conceive in the first year of unprotected sex. 10%, okay, the next 10%, okay, they conceive within first 2 years of unprotected sex. The next 10% they fail, okay, even after 2 years, okay, or during the 2 years of time they fail to conceive. Okay, so this is how normally you can see the rates. Okay, so 80% can conceive in the first year of unprotected sex, next 10% they conceive within first 2 years, and the remaining 10% they fail to conceive even within the 2 years. Okay, so this is about the definition of infertility, the types of infertility. Now what is the source of infertility? Okay, so remember, male has been, there can be some problem with the male counterpart in 30% of the cases. There can be problem with the female counterpart in the next 30% of the cases. Sometimes the problem can lie with both of them, that is constituting 30% of the cases, and sometimes even after every cause has been ruled out and everything has been studied, even in that situation there are 10% cases where the cause still remains unknown. Okay, so what are the factors which are affecting the prognosis? Okay, prognosis means whether what are the risk factors for fertility. Okay, so whether a couple will become, or whether a woman will become fertile or no. So what are the important factors affecting that prognosis? Number 1 is the age of female partner. So more than 35 years is the risk factor, because with increasing age the ovarian reserve comes down. Okay, so the most important factor to take into the consideration in infertility is the age of the female partner. Then we have to see whether it is a primary or it is a secondary infertility. So basically, if it is a secondary infertility, so there might be some kind of causative agent in between. For example, there is a TB of the female genital FGT, okay, that is causing some problem, or any kind of endometrial adhesions are there, endometriosis, something is there. Okay, so that cause can be treatable. Okay, so whether it is a primary, whether it is a secondary infertility, the duration of the infertility, for the time period the person has become infertile. Okay, so duration of infertility and the semen analysis report. Okay, so all these are the different factors which are affecting the prognosis. So today we are going to start in part 1, that is the male infertility. So before we start that, I am just going to re-revise some of the basic relevant anatomy of the male testis. As you can see, the male reproductive system over here. Okay, so they are basically comprising of the testes. So there are a pair of testes is there. Okay, so the male reproductive system, that is the male reproductive system that you see, basically you are having a pair of testes. Okay, and this pair of testes is producing basically the sperms as well as the testosterone. Now if you see, whatever sperms are produced in the testes, they are collected, stored and conducted via the epididymis, the duct deferens and the ejaculatory ducts. Okay, so this is how the sperms are stored. They are collected and they are conducted via with the help of epididymis and the ductus deferens. Then we have the seminal vesicle, which is a paired organ. Paired seminal vesicle is there, whose main function, okay, along with a single prostate. Okay, so there is a paired seminal vesicle along with a single prostate. So this is a single prostate and we are having paired seminal vesicle, whose main function is to produce the nutritive and lubricating seminal fluid. Okay, then after that we are having the bulbourethral gland. As you can appreciate over here, this is the bulbourethral gland which is secreting the lubricating mucus. Okay, and we have this penis over here, which is the organ of copulation or organ for copulation or sexual intercourse. Okay, so this is a basic relevant anatomy along with the basic physiology of the male reproductive system. Okay. Now, very importantly, we have to understand the basic physiology of the working of the hypothalamo-pituitary testis axis. So, basically, how is that the sperms are produced and how the testosterone is released. So, what is the axis? So, the hypothalamus, okay, stimulates the anterior pituitary with the help of a hormone, that is gonadotropin releasing hormone. So, with the release of GnRH, the hypothalamus is stimulating the anterior pituitary. This anterior pituitary is basically stimulating the release of luteinizing hormone and FSH under the influence of GnRH. Okay. So, what does this LH or the luteinizing hormone do? They stimulate the Leydig cells which are present in the interstitium of the testis, and they stimulate the Leydig cells to release testosterone. Okay, so they stimulate the release of testosterone, okay, from the Leydig cells which are present in the interstitium. So, the luteinizing hormone stimulates the Leydig cells and stimulates them to release testosterone. Now, what does the testosterone do? What is the function? Primarily, they stimulate the Sertoli cell to start the process of spermatogenesis. Okay, so they initiate the process of spermatogenesis, and secondarily, they are important for development of secondary sexual characters. Okay, or for puberty. At the time of puberty, development of secondary sexual characters. It is upon the testosterone, and they also stimulate the or initiate the process of spermatogenesis. Okay. Likewise, we are having the FSH or the follicular stimulating hormone, which is stimulating the Sertoli cells. Okay. The follicular stimulating hormone stimulates the Sertoli cells which are present in the seminiferous tubules, and these Sertoli cells, once they are stimulated, what do? They basically regulate the normal maturation of the sperms. Okay. So, they also help in the process of spermatogenesis. Okay. So, I hope this point is very clear. Now, very importantly, if you see the testosterone, if you see, they are giving a negative feedback. The testosterone, okay, once the testosterone is released, they are giving negative feedback at the level of the anterior pituitary and the hypothalamus. Similarly, the Sertoli cells are also give some signals of negative feedback signals are given, and they inhibit the activity of anterior pituitary and the hypothalamus. So, once adequate level of spermatogenesis is there, there is a need, there is a feedback inhibition of the anterior pituitary and the hypothalamus. Okay. So, I hope this point is very, very clear to everyone. Okay. So, what are some of the steps before and after the fertilization of the ovum? So, before I start with the process of fertilization, first you have to see the structure of the sperm. So, the sperm is comprising of the head, tail of flagellum and the end piece, as you can appreciate over here. If you see over here in the head, you are having very importantly the nucleus, and very importantly there is an acrosome which is containing proteolytic enzymes. Okay. Then in the axoneme, again you are having the axoneme, you are having the mitochondria, then you are having this axoneme, and you are having the end piece, the different parts of the tail or the flagellum, as we can appreciate over here. The head is comprised of acrosome, nucleus, and the tail of flagellum comprised of mitochondria, axoneme, and the end piece. Okay. Okay, so very importantly, before we enter how fertilization is taking place, very importantly, this sperm, okay, basically the sperm is traveling from the cervix, it is going into the uterus, then it is traveling in the fallopian tube, then it is coming into the ampulla, and it is at this region that the egg and the sperm, okay, they are meeting with each other and fertilization is taking place in the ampulla of the fallopian tube. Okay, this is how the basic process occurs. But remember, for the sperm to be able to travel from this particular cervix, okay, uterus, and to the fallopian tube, they have to undergo a process that is called as capacitation. And this capacitation is a process wherein the sperm becomes hypermotile. They achieve the ability to undergo acrosome reaction. What is the acrosome reaction? I will tell you later on, not an issue. Okay, so they achieve this ability to undergo acrosome reaction and to penetrate the zona pellucida of this particular ovum or the egg. So, what is it? Let me tell you. So, this is where the fertilization is taking place. So, capacitation is taking place at the level of the cervix, okay, wherein the sperms are becoming hypermotile and they have the ability to undergo acrosome reaction. So, now the sperm has got the ability to travel, it has entered the fallopian tube, it has come into the ampulla where it is meeting the ovum. So, at this point, if you see, this is the step number 1, pay a lot of attention. So, this is the sperm, this is the sperm head, as we can see, and this purple color is the acrosome. As I told you, the acrosome is having certain enzymes, that is the proteolytic enzymes. And what does proteolytic enzyme do? This proteolytic enzymes, they help in penetrating a layer that is called as the zona pellucida. So this blue layer is called as the zona pellucida. So basically the acrosome is releasing the proteolytic enzyme which helps in digestion of the zona pellucida. Not only that, it is also helping in digestion or complete dissolution of this acrosome as well. So whatever hydrolytic enzyme is released, they are combining with the outer plasma membrane of the ovum and helping in the dissolution of the zona pellucida, and as a result it helps in the penetration of this particular nucleus, okay, of the sperm. Okay, so it is helping in the penetration of the nucleus, okay, of the sperm. Okay, so this is what we are seeing over here, and you can see that the sperm egg has entered over here. Okay, basically the sperm, the nucleus of the sperm has entered over here, and then it is going to fuse with the egg. Okay, and then it is going to fuse with the egg, and then fertilization will occur, zygote will be formed. Okay, so this is how the steps are carried forward, and in the process of release of the hydrolytic enzyme, this acrosome is itself dissolved. Okay, it itself disappears. It disappears completely, it dissolutes. Okay, as we can appreciate over here. Okay. Now, after fertilization occurs, then there will be other steps. There will be 2-cell stage, 4-cell stage, 8-cell stage. Then there will be morula, blastocyst, and finally there will be implantation. Okay. So these are the rough and basic steps of fertilization. So whatever I have said right now, I am just going to read out the same. Okay, and you just pay a lot of attention. So basically, the testis is producing the spermatids. Okay, which is undergoing further collection and maturation in the epididymis and changing into a spermatozoon. Now, after ejaculation, okay, the sperms are undergoing capacitation, but capacitation occurs at the level of the cervix. Okay, so very importantly, that for fertilization to occur in vivo, that is, inside the female body, the sperm must undergo the process of capacitation and acrosome reaction. As I already told, what is capacitation? It refers to physiological changes in the sperm during its passage through the cervix. And what are the components? The sperm becomes hypermotile. They acquire the ability to undergo acrosome reaction, and they also acquire the ability to bind to the zona pellucida. Okay, so the sperm is going to then travel to the fallopian tube. Okay, and then they are going to undergo what is known as acrosome reaction. Okay, so the acrosome reaction, fertilization, 2-cell, 4-cell, 8-cell till the morula, till this stage it occurs in the fallopian tube. Okay, so what happens? The sperm, there is a binding of the sperm with the zona pellucida, which is going to induce what is called as acrosomal reaction. What is acrosomal reaction? There will be release of hydrolytic enzyme. So there will be breakdown of the outer plasma membrane. Plasma membrane of what? Of the ovum. There will be breakdown of the outer plasma membrane of the ovum by the enzymes of the acrosome, and its fusion with the acrosomal membrane with loss of acrosome completely. So as you can appreciate over here, all the enzymes have been released. Okay, as we have already shown over here, all the acrosomal enzymes have been released, and the acrosomal membrane and the outer plasma membrane of the egg, they have completely fused. Okay, and completely there is a dissolution of the zona pellucida. Okay, the zona pellucida completely dissolutes, okay, with the help of these hydrolytic enzymes, and the egg then penetrates inside, the nucleus then penetrates inside and fertilizes the egg, as we can appreciate over here. Okay. Now remember, this action, that is the breakdown of the outer membrane of the ovum, okay, this is necessary for fusion of the sperm and the oocyte membrane. Okay, and this is followed now after basically the acrosome and the outer membrane of the egg, they have fused with each other. That is followed by penetration of the zona pellucida of the ovum by the sperm. As we can see, the sperm is now getting inside, it is penetrating inside. Okay, it is penetrating inside. Okay. Okay, now after a sperm fertilizes a particular egg, after fertilization is there, the zona pellucida, once the zona pellucida is basically it is attacked or it is basically penetrated by a particular sperm, that is followed by hardening of the zona pellucida to prevent penetration by any additional sperm. So no more other sperms will not enter. The sperms penetrates and fertilizes the egg in the ampullary region of the fallopian tube, which is the region where fertilization occurs. Now remember, in the female reproductive tract, the oocyte, they have a 12 to 24 hour lifespan. Okay, they have a 12 to 24 hours lifespan. So the oocyte of the egg or the egg is basically having a 12 to 24 hour lifespan in the basically in the female reproductive tract. And a normal sperm, okay, after ejaculation can stay for 2 to 5 days in the female reproductive tract. Okay, it can stay in the female reproductive tract for 2 to 5 days. Okay, the lifespan is this much. Okay, is this point very clear to everyone? Okay. So basically, if someone asks you that what is the timeline where this can happen, so if the sperm is there for 2 to 5 days, so that is also the timeline for fertilization. In that 2 to 5 days, when ovulation occurs, in that time span, then fertilization will occur. Okay. So this is about the basic thing, how the sperm is produced, how it is carried forward, how after ejaculation, how it is traversing in the female reproductive tract, then what happens after fertilization, what is the time span in the fallopian tube, then it comes in the female reproductive tract, and then there is the implantation. Okay. Now we come to the main important first, what are the causes of male infertility? So sometimes they can be idiopathic, there is no known cause. Then we can have a hypothalamic pituitary dysfunction. So there is a problem at the level of the hypothalamus or at the level of the pituitary. Such kind of male infertility, it is called as, the cause has been called as hypogonadotropic hypogonadism. Then sometimes the problem can lie with the testis. There can be testicular disorder. In that case, the FSH LH levels will be high, but the testosterone levels will be low, and such a case is called as hypergonadotropic hypogonadism. So the testicular dysfunction, if you are looking at over here, so what are the causes of testicular dysfunction? We are having radiation or the use of cytotoxic drugs, general factors like stress, marijuana use, alcoholism, okay, heavy smoking, use of anabolic steroids or cocaine, mumps or orchitis after puberty, varicocele. The most common cause of reversible infertility in men is varicocele, that is nothing but the dilatation of the pampiniform plexus. Then undescended testis, that is cryptorchidism, is one of the causes of infertility. Endocrine disorders like diabetes mellitus or thyroid dysfunction. So when I am speaking about these causes, so in the real life scenarios, if you are practicing, you have to do these tests, T3, T4, TSH testing, test for blood sugar level has to be done, physical examination has to be done to rule out any varicocele or any undescended testis. Okay. History has to be taken for all these things, whether stress is there, alcohol consumption, heavy smoking is there or no, or any other drug intake has been there. Then genetic disorders like Klinefelter syndrome, immotile cilia syndrome, that is Cartagenes syndrome, or cystic fibrosis, if there is any such history of a genetic disorder, or you have to carry out chromosomal analysis to rule out these disorders. Okay. So these are the important causes. Then the fourth important cause, if everything is all right up till here, so the testis is functioning normally, there is no problem with the testis. So now I told you that the sperms are carried, okay, with the help of the, they are collected, stored and transported via the epididymis, okay, the seminal vesicles are there, and via the vas deferens. Okay, so if there is any problem over here in that particular aspect, so infections of the epididymis, if there is TB, gonorrhea, chlamydia of the epididymis, if there is infection of the prostatitis, the vas deferens are mainly carrying. So in case of cystic fibrosis, there can be congenital bilateral absence of vas deferens, so it can lead to cystic fibrosis. Then vasectomy, if there is any history of vasectomy, sometimes you are doing the semen analysis after vasectomy to see the competency of that particular surgery, whether the surgery has been performed properly or no. So if there is a dysfunction of the passage and the accessory sex gland, that can also lead to male infertility. Then comes everything is all right in your body, so some problem is there with the sexual act. So very commonly impotency or erectile dysfunction can be there. Hypospadias, wherein the opening is below, okay, there are different types of hypospadia, so that when the opening is below and not in front. Defects in ejaculation, there can be retrograde ejaculation, whether ejaculation is going back into the bladder, okay, or there is a premature ejaculation, just you are starting to insert into the vagina and prematurely ejaculate is happening, or the ejaculation is there but there is absent ejaculation. Okay, so basically retrograde ejaculation usually occurs in conditions of prostatectomy or in conditions of testicular carcinoma. So how do you investigate a case of male infertility? Sometimes male infertility is asked as a full 10-mark question, or sometimes they might just ask you a short note 5-mark question as the investigations of a male infertility. So whatever be the question, you always should write, because as a pathologist we are here to be a detective, we have to investigate a case. So always investigations of male infertility should always be included in your answer. So very importantly, your investigation starts with the history. You first see what is the habit. History of alcoholism is there, history of smoking is there or no, any other stressful factor is there, okay, any history of cytotoxic therapy. So whatever general factors we have discussed over here, you have to rule out, okay, whether any drug history, cocaine or drug intake has been there. Then the type of sexual practice. Now remember, usually it is said that at the time of ovulation, you should practice the sexual activity not every day, but leaving one day. Why it is? If you practice every day, then also your testis needs some times to replenish the reserves, right? So the frequency of the sexual activity should not be very frequent, okay, and it should not be very less. It should be optimum. So sexual practice and all the other things, whether they are practicing, whether they are having any kind of, sometimes what happened that the individuals, they are not talking to each other, or they do not have, means everything is all right, but they are not suited to each other very well. So their sexual activity is not that much. So sometimes mental hindrance is also there. So psychiatric evaluation is also very important. Then whether any history of erectile dysfunction is there, premature ejaculation is there, or any STDs was there previously, any history of surgery, drugs or systemic illness like diabetes, thyroid, these history has to be taken, any drug intake, any drug the person is taking or no. Then the physical examination, you have to measure the testicular size, because if you have done the semen analysis and there is azoospermia, then depending on the testicular size, you have to go further. If there is any undescended testis or hypospadias or varicocele, you see the distribution of body and facial hair, okay, then congenital bilateral absence of vas deferens if it is there or no. So all this can be known via the physical examination. After that, you can carry out the semen analysis. So very important, semen analysis is very important exam question. You have to know the semen analysis very deeply. Now, after we complete the part 1 and part 2 of our lecture on the infertility, we are going to, after that, we are going to read in details about the semen analysis according to the latest WHO 2021. Okay. So, evaluation. So, first of all, in the semen analysis, when the volume of semen is very low, less than 1 ml, you have to examine the post-ejaculatory urine. If the post-ejaculatory urine, they are containing the sperms, then the condition is that of retrograde ejaculation. Okay, the diagnosis is made. If it is negative, if the post-ejaculatory urine is negative for sperm, then you carry out further investigations like transrectal ultrasonography for any seminal vesicle abnormality or to rule out any ejaculatory duct obstruction. Then evaluation of azoospermia. Suppose you have done the semen analysis. Now remember, just a single report of semen, abnormal semen analysis report is not enough. You have to do at least 2 semen analysis report at least 1 month apart, okay, to go for any further evaluation, okay, to label a person as azoospermia or male infertility, to report as such. So once you have seen azoospermia, once you have reported azoospermia, then you look at the testis size. If the testis has a normal size, then mostly it is an obstructive azoospermia secondary to either epididymal obstruction by chlamydia, or secondary to vasectomy, or secondary to congenital absence of vas. In this case, basically you should carry out genetic testing for the CFTR gene, okay, for the defective CFTR gene. If the testis is small, soft testis, then it is the case of a non-obstructive azoospermia. Very importantly, carry out hormonal analysis. So if all the 3 hormones, that is the FSH, LH and the testosterone levels, all of them, they are low, it is a case of hypogonadotrophic hypogonadism. If the FSH, LH levels are very high and the testosterone levels are normal or low, then it is a case of a hypergonadotropic hypogonadism. And it is a case, indicative of some problem at the level of the testis. So there can be primary testicular failure. So genetic studies have to be done to rule out Klinefelter syndrome. Okay. After that, after semen analysis, you can do the chromosomal analysis, okay, so as to report Klinefelter syndrome. So karyotyping has to be done, XSY. Again, mutational study of the CFTR gene to rule out cystic fibrosis. Now remember, if all the values of semen analysis are normal according to WHO, then no further testing has to be carried out. Only if at least 2 semen analysis is abnormal, okay, which has been done at least 1 month apart, then you carry out further testing like hormonal studies like FSH, LH and testosterone studies. So the next important study investigation is the hormonal analysis. As I have already explained before, you see these values, okay, if all the 3 values are low, then it is a case of either hypothalamic or pituitary disorder. We call it as hypogonadotropic hypogonadism. If FSH, LH are high, whereas the testosterone levels are normal or low, then it is pointing towards testicular disorder and you label it as hypergonadotrophic hypogonadism. And if all the three levels are normal, then it is consistent with the obstructive pathology. Some kind of obstruction is there in the passage, or there is a dysfunction of the accessory glands of the prostate and the seminal vesicle, like that. The next option in case of male infertility is to go for testicular biopsy, which can be both diagnostic as well as therapeutic. So diagnostic testicular biopsy is done in men with azoospermia but who are having a normal testicular volume and normal hormonal analysis. It is done to distinguish between obstructive and non-obstructive azoospermia. Okay, whereas therapeutic testicular biopsy is done in conditions wherein the for therapeutic purpose, when you do that, you can obtain the spermatozoa can be obtained and can be used for assistive reproductive technology, ART technology. Now, what are the informations which are obtained from testicular biopsy? So, hypospermatogenesis, where all stages of spermatogenesis are reduced. Maturation arrest, where complete arrest at particular stage of spermatogenesis is there. Germ cell aplasia, where no germ cells or only Sertoli cells are there. Tubular and interstitial fibrosis, you can see testicular microlithiasis can be seen, and it is also a risk factor for testicular carcinoma. Testicular carcinoma in situ. Now, testicular biopsy is a risk factor for development of anti-sperm antibodies. Remember this point very, very clearly. So, with this, we have completed the investigations and we have completed in details about the male infertility. Stay tuned till the next lecture, wherein we are going to discuss in details the female infertility. Thank you very much for watching this particular video.